Welcome to Emergency Medicine Topics in One Coffee. I'm Alan Giles, I'm an emergency physician, and today we're going to talk about meningococcal sepsis in infants. Now, Neisseria meningitidis, the bacteria, causes meningitis and it causes meningococcal sepsis. These are two separate things. Meningitis has a death rate of 1 to 5%, whereas meningococcal sepsis, you're getting septic shock, coagulopathy and end organ failure, and that's why it's got death rates up to about 40%. Now, how do you clinically present? Well, it's actually a pretty fast illness. Within about 12 hours, children will be lethargic, they'll be off their food, they may complain of aches in the legs, they may complain of back pain, and they may vomit and have a high temperature. When they develop the characteristic purpuric rash, that usually occurs about 12 to 24 hours after the initiation of any of the symptoms. Now, this rash is something that you already know you've got coagulopathy occurring and can rapidly progress. Okay, so with these patients, if you're in the emergency department and you get rung from a general practitioner who says, I'm concerned that I've got a patient here with meningococcal sepsis, make sure that they, if they haven't already done it, gives the child intravenous, preferably benzyl penicillin. Between the ages less than 1 year, 300 milligrams. Between the ages of 1 year to 9 years, 600 milligrams. Now, this is a disease that normally occurs between about 3-4 months up to about 4 years. If they can't give it intravenously, they can give it intramuscularly. If the child is allergic to penicillin, they can give ceftriaxone 50 milligrams per kilogram intravenously or intramuscularly. When the child comes to the emergency department, this is a team resus. It must be recognised earlier, and you're going to need good nursing staff, good medical staff, good paediatric backup, and the involvement of social workers nice and early. There's certain things that you need to address really early. You need to have a look at the cardiovascular status, the respiratory status, and of course the neurological status of the child. You need to get early vascular access, so an intravenous or an intraosseous is the initial approach that should be taken. Remember, take an early glucose. If you forget now, you might be forgetting for the next 10 or 15 minutes. Your priority now is to get that intravenous antibiotic in if it hasn't already been given. Remember, we're talking ceftriaxone 50 milligrams per kilogram. Be also be careful with, there's a lot of, people are going to be nervous, people are hyped up. Make sure that you've got direct communication lines between yourself and the nursing staff back so you know exactly what dosages are giving. Assess the child's cardiovascular status. Look at their pulse rate, their capillary return centrally, and of course their blood pressure, but make sure they've got an appropriate blood pressure cuff for their arm. They will need to have a fluid bolus. They're going to be vasodilated. Fluid bolus of about 20 mils per kilo of normal saline. They're likely to require more than this for severe meningococcal sepsis, and you can reassess them after 20 mils per kilo to give another 10 mils per kilo of normal saline, or another 10 mils again of normal saline. Now, it's important also with the blood test, I think, to make sure you're looking at venous gases really early. The venous gas is going to show you what the metabolic acidosis level is, what the lactate is, but also what the respiratory compensation is. Is the child breathing up to compensate for the acidosis, or are they getting tired and the CO2 is starting to rise? In which case you might be thinking, well, I'm going to have to get some help because we're going to have to probably intubate this child. These children at this point, they should involve, for most mixed emergency departments, they're going to involve NETs for transfer. Now, a few words about NETs. NETs is a high quality service, but they're not next to you. Okay, so they're going to take a little bit of time to get a feeling from a distance how they can safely get to you and keep the child safe, pick up the infant and take them back to the children's hospital. So this can take a little bit of time and can be frustrating. If you're the person running the resuscitation, continue doing that and allocate another reasonably senior person to discuss the case with NETs. Now, if this child we're saying might be getting worse and might need ventilation, intubation and ventilation, there's a couple of important things. You're going to be giving positive pressure. If you don't fill them up with fluid, with those intravenous boluses, they're going to crash their pressure on intubation. So give them the intravenous boluses to fill them up and get ready with an inotrope infusion in case you need it. The other thing is with induction, let's talk about using ketamine. Ketamine is the ideal induction agent, and it's about 1 milligram per kilogram of ketamine IV as a bolus. Okay, so we're going to safely get the child out. NETS comes, NETS takes the child safely away to Children's Hospital. There's a few things left over. This has been difficult for all the people inside the team. It's stressful. It's a child that has, we know, a potential outcome that might lead with either morbidity or mortality of the child. So it's important to come together as a team afterwards and debrief, because resuscitation of children like this, we don't do that often, and it's difficult for everyone, including me. So I need you to be debriefed as well as everyone else. Okay, well, I reckon that'll just about do for meningococcal sepsis in the infant in one coffee. Thanks.